All right, everyone, we are 1 minute past the hour, depending on where you are. It's 1:01 where I'm at. My name is Lynn. I am one of the CityMatCH managers, and thank you for joining us this afternoon on our Learning Network webinar. We're really happy to have you here. As you may or may not know, CityMatCH is in Omaha, Nebraska, and that's on the ancestral land of the Omaha and the Oceti-Sakowin nations. And today I am delighted to feature Alyshia Macaysa on our webinar about decolonizing gender in parent and child health. And Alyshia is a Kanaka Maoli Ilocano Filipino health equity strategist and community organizer. She was raised in Southeast San Diego, politicized in the Bay Area, and is now doing systems change work in Portland, Oregon. Alyshia's work primarily consists of community-based initiatives focused on racial equity. The heart of her work and her approach is decolonizing public health practice and shifting power back into the communities most impacted by injustice. This journey has led her work across workforce development, affordable housing, public health, and tech sectors. In 2019, she was selected by the City of Portland to serve as one of 3 equity consulting advisors for their Smart City PDX initiative, and she began her service as a board member for the Multnomah County Public Health Advisory Board. She is nationally recognized as a health equity practitioner and was recently inducted into the Robert Wood Johnson Foundation's 4th cohort of Culture of Health Leaders. And with that, I'd like to welcome you, Alyshia, to our webinar. Thank you for joining us today. For the audience, we do have the Q&A box available. So as Alyshia is presenting and you have a question, please feel free to make use of that. And for now, I've disabled the chat just because there were several hundred registrants in our webinar today. And hopefully, we can minimize the chatter in the chat, but I think Alyshia would be open to discussion at the end of our webinar. And so if there are any questions, again, please feel free to make use of the Q&A function. And I'll go ahead and pull up your slides now, Alyshia.
Thanks, Lynn.
All right, there you go.
Awesome. Okay. Well, aloha mai kako, like Lynn mentioned, my name is Alyshia Alohalani Macaysa Farrakata. You can just refer to me as Alyshia in this space. My pronouns are she, her, hers, and I will be leading you all today through some reflections and conversations. So again, thank you for joining today's session on decolonizing gender and parent and child health. For those who joined the CityMatCH conference in September of last year, this will mainly be a repeat for you. So I welcome you, especially once we get towards the end and I put some discussion questions up. I welcome you to chime in the comments to share your learnings, reflections, and how you've integrated this work since we last met. I also just want to mention the caveat and reality of working from home, which is that my mom likes to FaceTime me constantly, only during important moments, of course. So if you hear a ringtone, I'm sorry for it in advance. It's probably my mom, but I'll do my best to decline her call while I'm spending this next 90 minutes with you all. I also just want to take a moment to ground us in a land acknowledgement from the place in which I do my work. And so today and all days, I want to honor and acknowledge the Indigenous people who have stewarded these lands since time immemorial. The Klamath tribe of the Southern Oregon Plateau, the Burns Paiute of the High Desert East, the Coquille of Southern Oregon's coastal forests, the Confederated Tribes of Grand Ronde in the Northern Coast Range, the Cow Creek Band of Umpqua in the Southern Oregon foothills, the Confederated Tribes of Umatilla in the Blue Mountains, the Confederated Tribes of Siletz in Oregon's northern rainforests, the Confederated Tribes of Coos, Lower Umpqua, and Suislao on the wind-blown southern coast, the Confederated Tribes of Warm Springs on the sunny eastern slopes of Oregon's Cascades, and we would like to recognize all other Indigenous communities who have not been federally recognized and deserve the recognition. I also want to express my appreciation and respect for Indigenous people's inherent kinship beliefs when it comes to land, especially since those beliefs were restricted for so long. All right, well, mahalo for sitting with me through that. I also just want to share a little bit more about me, but thank you, Lynn, for giving that wonderful introduction. Just a little bit more about me before we dive in. So like Lynn mentioned, I'm currently a health equity strategist and independent consultant. I really identify primarily as a community organizer. I'm the incoming executive director of the Oregon Pacific Islander Coalition. And like Lynn mentioned, I am a Robert Wood Johnson Foundation Culture of Health leader. I also want to name that I am part of a Native Hawaiian and Filipino lineage where my paternal great-great-grandparents were born into the Kingdom of Hawaii and died in the illegally occupied state of Hawaii. The heart of my work, again, is integrating a decolonized public health practice into community-led racial equity initiatives. I also just want to say before I dive into all of the work that what I'm sharing is not solely mine, right? So I have the honor of being a messenger or storyteller for a body of collective work that happens, through my organizing collectives, through research projects, through teachings from my family, from my own cultural practitioners, and even the work and ideas that participants shared in September. So I get to pass on the wisdom that they shared with me with all of you today. I also want to note that I'm not necessarily a formally trained researcher or data scientist, though my mentor would probably urge me to push back on that notion. My technical skills really come from designing community-led research models in collaboration with researchers and data scientists. So I really think of myself as a community engagement and community organizing expert more than anything. So let's get into it. What are we going to talk about today, right? So we are going to talk about what it means to do decolonizing work when it comes to the field of maternal and child health, or as I like to call it, parent and child health. So there's a lot of ways for us to talk about decolonization. Some of its most crucial aspects being political sovereignty, ownership over land, and preservation of culture. Today, I'm going to talk about decolonization in terms of preservation of culture, specifically through our understanding of gender and familial structures. And there's some things that I want us all to consider as we enter into this conversation. One, we are having this conversation in English. There's only so much you can do in terms of decolonizing work when that work happens in English. And I unfortunately do not speak Olelo Hawaii. I speak and read and do my work and write in English. I also want to name that I can't speak for all queer and trans people of color. I'm going to allude to a lot of my personal reflections and work that I've done in the community. But again, I can only speak to the history and experience that I know and invite collective visioning amongst all of us for how these lessons that I'm sharing may apply in your context or in other contexts in which you do this work. I also want to name that this space honors humility, right? And recognizes how pervasive cis hetero patriarchal systems, that's a mouthful, are in our social conditioning. So I'm not necessarily concerned, especially once it comes time for discussion, of folks using the right language. I want everyone here to be invested in learning. So I want you all to come with the right intentions and I'll do the same, right? So think about things as you're participating in the chat or the Q&A. Am I asking this question to learn, to understand before I make a judgment, to investigate my own frameworks? Or am I asking the presenter to legitimize her cultural traditions with my Western framework? So just some things to think about. And we can go to the next slide, Lynn. So ultimately, today's story that I'm going to tell you is a story about power, with our central concern being racialized health disparities. And so I learned about this concept of power as a public health issue when I first started in birth outcomes work. And it's a quote and a concept by Dr. Adewale Troutman. And in the extended quote, Dr. Troutman says, part of good public health is empowering communities. And I don't think we should shy away from that. And empowering communities means creating those conditions where people become empowered and make the changes they need to control their lives. Power is a public health issue. So as I started to listen and reflect on this concept, it really had me connect to this field of creating equitable birth outcomes, right? I started to think about toxic stress and weatherization driving the disparate birth outcomes for people of color, higher levels of cortisol as a response to living in socially subordinate positions. And so again, I started to think even further, well, what power do we have as people of color when white folks are the comparison group in our data around racial equity and around health equity? And what power do we have when Euro-Christian ideas of the gender binary and the nuclear family drive what data we collect on birth outcomes and health behaviors? And again, what power do we have when people of color are talked about through the lens of our racial and ethnic identities being the risk factor? And so the points that I'm trying to make here, right, are that when we look at uh, BIPOC health outcomes or the health outcomes of Black, Indigenous people of color in relationship to what white folks have, what we're doing is making an assumption that what white folks have is what people of color need, that white folks are then the beacons of good health. Again, another quote from my wonderful mentor, Dr. Eileen Doldelau. And so I started to think, well, what do we actually need, right, if power is a public health issue? Well, we need power over our stories. When we have power over our stories, AKA our data, we have the power to transform our conditions and our lives. So I'm getting to this concept of self-determination. I know it's a lot of big words and concepts, so just move with me through it. But self-determination and the idea that our culture is actually a protective factor. So what does exploring all of that actually look like? So let's go to the next slide. Awesome, thanks, Lynn. So in about 2018, the Multnomah County Pacific Islander Coalition was collaborating with the Multnomah County Public Health Division and Dr. Eileen Doldelau, who again, I will continue to mention a bunch in my presentation today. And so we were collaborating on what we called the Pacific Islander Data Project. And so in about May of 2019, we decided to host a series of workshops and conversations with our different Pacific Islander community leaders and community members. And so one of the workshops that we hosted was on parent and child health. And the goal there was to share birth outcomes data, give the community an opportunity to challenge that data, and share what data they wanted included in their stories. So in initially processing that data as we were going through our planning phase, we saw that less than half, so about 42% of COFA citizens accessed early prenatal care. And so for folks who aren't aware, in Oregon, there is what we call a Compact of Free Association Premium Assistance Program, and it provides free health insurance for low-income citizens of the Republic of Marshall Islands, the Federated States of Micronesia, and the Republic of Palau. And so when we were looking at this data in terms of early prenatal care access, you know, the first assumption we had was one really based in Western-centered frameworks, right? That data would immediately tell us, like we should probably increase access to early prenatal care for birthers who are COFA citizens. So in turn, what we expected to see were much poorer birth outcomes when it came to delivering babies at healthy birth weights. And obviously there's a lot of other factors that go into healthy pregnancies and healthy births. But we were surprised to see that 92% of babies born to COFA citizens were born at healthy birth weights. So in kind of reframing, rather than looking at the deficits, the 8%, we started to say, well, for those 92%, like what's happening here? What's working for those folks, right? What story or practices are Western-based methodologies failing to capture? And so when we opened up that conversation with our Palauan leaders, you know, they contested that while they may not necessarily be accessing early prenatal care in Western hospital systems, care for the pregnant person in Palauan culture is a vital part of their practices and traditions, which they continue to practice as much as possible in the US. So typically, and this is what they shared with us, is that the pregnant person in Palauan cultures is surrounded by a network of support, right? The pregnancy and birthing process is not simply a matter between a nuclear heterosexual family, AKA mom and dad, but between the birther and their broader community of support. So oftentimes that community of support looks like a collective of women who are cultural practitioners, and they are responsible for keeping the pregnant person off of their feet, making sure they have the resources so that that pregnant person does not have to go into work during this critical period of health, tending to their health and healing needs, doing feedings, massages, ceremony. And so through this process and conversation, we were able to think through how to highlight more meaningful intervention strategies and ask more relevant questions, right? So we were starting to think, well, how do we lift up this practice of community-based support for pregnant people who currently does not have access to a community network like such, who's experiencing social isolation from other Pacific Islanders? And what about Western systems and structural racism prevent communities from preserving these practices? What are the possibilities of shifting the focus of our investments solely from early prenatal appointment access in Western-based care to resourcing these community-based practices? Right? Because it's important for us to recognize that for many, even though, it's not just an access issue, right? Western hospital systems are not always safe or effective for everyone. And more importantly, lifting up these practices gives power to pregnant people to experience pregnancy in the ways that best resonate with them. So we can go to the next slide, Lynn. So again, now I have another set of questions, right, that I was coming to where I was like, well, what challenges or barriers are preventing us from practicing our cultures to its fullest extent? And what does gender have to do with all of this? So I think it's really critical for folks to understand that pre-colonization, queer, trans, and gender expansive people had their roles in traditional indigenous Pacific Island societies. In Hawaii, our mahu, which there is technically no direct one-to-one translation, but you could think of it as trans or gender expansive people. So our mahu played vital roles as teachers, as healers, as cultural practitioners, as artists, as leaders. And when foreign powers came to Hawaii, they made it illegal to practice our language and our culture. So with that came the suppression and forced exile of key figures of our culture, including trans people. So our language also captured our relational worldview and governance structures, right? It is in our language, embedded in our language, that you see that we speak of land as something familial rather than as property to own. And we speak of governance as collective accountability rather than hierarchy. And we speak of sexuality as something as fluid as the relationships pre-colonial environments allowed us to have. And so it was the foreign powers who forced the gender binary upon us, telling us only men and women exist. A similar history also exists across the Pacific Islands, from Letis in Tonga to Fa'atane and Fa'afafine in Samoa, and so much more. So it's critical then to understand that queer and trans identities are inextricably linked to culture, not something separate from it. And that this suppression or erasure of our identities was purposely designed to dismember our cultures. So if we as folks who want to do work around racialized health disparities want to uproot white supremacy from our practices or decenter whiteness, then we have to have a more inclusive understanding of gender and sexuality, and more broadly, familial and community structures. And we can go to the next slide, Lynn. And so again, here's Dr. Doldalau. She might be in the audience. So hi, Dr. Doldalau. So this is one of my favorite quotes from her, which is, "You will not find what you are not looking for." So as I've been leading us up to this moment, right, the idea here is that Western-based methodology is incredibly limiting, especially when it comes to understanding the Pacific Islander community, for example, right? So its current practices and norms, it We rarely get disaggregated data around race and ethnicity in a meaningful way. So health outcomes for Pacific Islanders, for example, are often obscured by the aggregate API or Asian Pacific Islander category. And like I mentioned earlier, right, we have folks of color being compared to white people. So again, this framing of white people and Western practices as the beacon of good health, rather than like culture and traditions and community as the beacon of good health. And also that our good quality data on queer and trans people and intersectional data on queer and trans people rarely exists, right? So our stories as queer and trans folks of color are often limited to stories on our sexual activities, risky behaviors, or STIs. So we're rarely talked about in the broader sense of the social determinants of health. And that's a problem. And let's go to the next slide. And what those practices fail to capture is that queer and trans Pacific Islanders, for example, in both a historical, which I just laid out, and contemporary sense, really play a key role in our communities as stewards of our cultures. So in the Pacific Northwest, for example, which is where I'm doing my work from, our queer and trans Pacific Islanders, so our leaders, our organizations, often advocate for the broader community. So we are kumus, we are poets, teachers, community organizers, community health workers, we are researchers, and we lead key aspects of coalition organizing for our Pacific Islander communities. We exist. And we also have families as queer and trans Pacific Islanders, and we are involved in the process of supporting families. We get pregnant, we birth babies, we lose babies, we adopt children, we provide cultural ceremony and community to support our pregnant people. And we continue to serve our communities and practice our cultures. The difference here is that with the legacy of colonization, we are often negotiating between acceptance into the broader white-dominated LGBTQIA plus community and maintaining connection to our cultures and families. Oftentimes we're put in this position of choose one or the other, but you can't have both. We're also often negotiating our physical safety with the freedom to fully express ourselves or receive access to the healthcare that we need. I think that statement is incredibly relevant in this moment, in this last year, where we see a lot of anti-trans legislation being passed across the country. And so we can go to the next slide, Lynn. So there's some things that I want folks to consider. The question here becomes, again, another question, right? But that is the nature of research. The question becomes, how do we create inclusive practices to tell meaningful stories and develop useful strategies in addressing health inequities? And so, I'm just going to run through some details here, but Lynn, you're also welcome to start to open up the chat if folks want to start to interact.
Okay, sure thing.
Thanks. So I think going to this piece around community-led research, right? And going back to our values around power and ultimately self-determination over our stories. So again, capturing data on gender and sexuality is incredibly fluid and it's really complex work to do, right? Trying to figure out categorization and appropriate terms to use is a tough job. And the terms really are contextual, right? It depends on things like the population that you're working with. What is their connection to their culture? Also, where is that community in adaptation of gender inclusive words? Right? Language is also always evolving as identities do, and each person has their own meaning for a term. Also have to consider the context that culturally based terms are often adapted to strip them of offensive and negative context and do not have proper like one-to-one translations in English. So the example that I can give you, right, is like the term queer. I think it's very much generational and geographical in terms of its use. In some places, it's still used in the pejorative. In other places, right, that's a term that's been reclaimed to not only identify the way someone expresses their sexuality, but also some of their political beliefs around gender and familial and relationship norms. Mahu, the word that I was sharing earlier, or the identity that I was sharing earlier, is another good example of that. I think socially, in like mainstream, like state of Hawaii culture, Mahu is very much used as a derogatory term. But when we go back to the original cultural teachings of the word Mahu, there's quite a lot of power and sacredness to that identity. And so I say all of these things because we can't possibly tell the complexity and true meaning of these identities and therefore stories without engaging the community in our research and in our data collection. That's why that work is so important, because everything is so contextually based and we need to learn from our communities. Well, what is the context in this situation? And like I've mentioned throughout every single slide, right, we need to start to tell strengths-based stories that decenter whiteness, right? Going back to our value that actually culture is health and culture is strength, right? By decentering whiteness, we're able to lift up the strengths that are already within the community and figure out, how do we invest in that? Right? So going back to our example with Multnomah County that we highlighted with positive birth outcomes, 92% of babies born to COFA folks were born at a healthy birth weight. What's working for them? What's going right in that situation? And how do we preserve and honor that, right? So through that work, right, we were allowed to understand, or we had this opportunity to understand what culturally specific traditions around birth were keeping folks healthy. It ultimately drove us to ask, what healthy birth practices and supporting resources do 92% of COFA folks have that the other 8% do not? And why is that? And ultimately, it helped us develop more meaningful and culturally specific intervention strategies to creating healthy birth outcomes, which we're still on our way to doing that. And so again, just driving that point home that when we decenter whiteness in our work, we can make room for a more expansive reality about what the role of culture and therefore the role of community-based support and queer and trans cultural practitioners play in health equity and health outcomes and birth outcomes. So I know those things can feel a little broad. So I also wanted to provide some direct application considerations. And I have to give a big shout out to the participants from the September workshops, because I was able to go through, how they were implementing this work in California, in Colorado, and some of the insights and tips that they shared. So I'm going to take a moment to highlight some of those things under these broader categories that you see on the screen. So one thing is, consider neutralizing your language, right? In how you refer to people broadly. Think of parent and child health versus maternal and child health. There's also, of course, saying hello everyone versus hey ladies. Birther versus mom or women. Sorry, I'm seeing my notes here. There were so many good ideas. Right? But we really want to be more inclusive to support people who are marginalized in this work and folks that we fail to engage in these important conversations, like the parent who's not pregnant. They're still a critical part of this process, right? And so other tips include like parental interview versus maternal interview. One of the participants of September, who I believe was part of is part of the Colorado Department of Public Health and Environment, said that, through their learning around gender inclusive language, a colleague shared a study that she did and learned that fathers actually felt more included and engaged in the conversation when gender inclusive language was used, right? So people who identified as women typically did not notice the shift in language, and birthing parents who didn't identify as women felt recognized and seen for the first time in any sort of prenatal experience. The other practical thing to think about is when you're asking research questions, when you're doing intake forms, right? Get down to the function of what you are asking for, right? For example, chest or breastfeeding parents instead of mothers. The place where I received my care, which is a LGBTQ specific primary healthcare clinic, asks things like, Are your sex partners a person with a penis, a person with a vagina? Or are you the person who is pregnant or the parent who is not pregnant? Uh, Again, very practical and specific questions like, what is your relationship to the child being born? Are you the pregnant parent? Are you the non-pregnant parent? Are you the genetic person or genetic donor? Excuse me. And again, neutralizing some of our language, like thinking about saying pregnancy associated death versus maternal mortality. And so those are just some of the examples that I've learned about, that I've implemented, that was shared with me last September. And so I want to go to the next slide. So really what I wanted to do was open it up for discussion. So like I said, all of those examples that I just, or a good amount of those examples that I just named for you all, it was based on a conversation that I had had with participants in September. So I want to recreate that same opportunity here, and I'm posing questions back to you all. So what questions or hesitations, reactions, or comments do you have? How do the roots of colonial thought show themselves in the field of parent and child health? And what do you believe needs to change or is ready for change in this work to create more meaningful solutions? So we can open it up now. If folks want to share in the chat or respond in the Q&A, I'd be happy to open that up.
Yes, thank you, Alyshia. Like Alyshia mentioned, the chat is open, and as you're typing in the chat, you have the option of sending it to just the panelists, so only Alyshia and I will be able to see it, or you can have it sent to all panelists and attendees if you'd like the other attendees to be able to see your comment as well. And there is also the Q&A box too, if you'd rather submit questions through that. But Alyshia, while people are gathering their thoughts and thinking up good questions for you or responses to your questions, we did receive a comment in the chat that emphasized the strengths-based approach and stories that decenter whiteness too in public health.
Ooh, let's see. Thanks for calling my attention to that, Lynn. And what else? Challenge. So funding mechanisms that require use of predetermined categories and language. Yeah, absolutely. And so I'm interested to understand, from folks kind of what has worked in creating those systemic shifts that are needed to transform our funding and investments. Ooh, another question. What is she, her? Good question. So she, her, those are the pronouns that I use, right? So that's the way we identify or the way we talk about people in third person. So when we use gender pronouns or when we say our gender pronouns, that's really a way of preventing us from making assumptions about how people identify. So even though you may look at someone and say, oh, that person identifies or that person looks like a woman, therefore I'm going to refer to that person using she or her in third language instead, or in third person, excuse me, lots of words. Some folks use he, him, his, right? So it can be someone who does identify as a cis man, as a trans man, as a non-binary person. Some folks may use she, her, hers. Some people may use they, them, theirs. Some people may just want you to call them their name or something else. But that's the reason why we put our gender pronouns in there. Ooh, we have lots of good questions here. And I'll also encourage everyone, because you all are the ones working oftentimes within these really challenging systems, read through the questions as well and see what offerings or reflections you can provide to folks. I always encourage the participants to share and highlight their work. I think that's the most exciting part of these workshops. So let me get through what's here. So there's a question on how do we find trusted, appropriate alternative titles for addressing patients / folks we work with. And Ella, I'm wondering if you can actually expand on that question more. Ooh, Madeline, that's also a good reflection here. What are folks' thoughts about the use of neutralizing or degendering language versus making language more inclusive of people of all genders and sexes? Yeah, that's a good question, Madeline. That's really making me think. Oh, and I'm getting some Q&A as well.
Mm-hmm.
Sorry, we're getting lots of interaction. I'm like, where do
we begin?
Sorry, folks. I'm just trying to read through all of your really thoughtful questions. I'm first going through the chat, and then I'll go through the Q&A as well. But yeah, I'd love to have a conversation with folks on what are your thoughts about the use of neutralizing or degendering language versus making language more inclusive of people of all genders and sexes. You know, my initial reaction is like figuring out a way to kind of do both, right? Especially in our community engagement and the way we present the conversation. I think you're right, Madeline, in the concepts that you're, in the point that you're making here of like needing to be more inclusive in our language to say, hey, when we talk about pregnancy and we talk about birth, we also include and recognize folks who do not identify as women or who do not identify as moms or who are not necessarily connected to this pregnancy in a biological manner. So I think there's benefits to saying, yeah, let's have more inclusive language around gender and familial structures. And then at the same time, I think there's really specific contexts where it's really useful to kind of, yeah, now I'm like, ooh, like what is the meaning behind neutralizing or degendering? But I guess going back to what I was sharing earlier, there are like on like patient intake forms, for example, and something that I and folks in my community have really appreciated when it comes to queer and trans health is, you know, rather than asking us and making assumptions about like, okay, well, if you're this gender identity or if you're this sexual orientation, then these are your assumed sexual activities. Like in that situation, I felt like it was really useful for us to just get down to like, well, what's the function? What are you trying to ask me, right? Of like, you know, what, not necessarily what kind of people, but do I have sex with folks who have a vagina, a penis, etc.? And so I could see, you know, there's a benefit to both too, but I think there's something else that you're digging into around like neutralizing and also like what's the harm, you know, or some of the negative impacts that I'm not foreseeing by using that term. So I appreciate that question. I'm going to go to Samantha's thought here, which says, I've been working to utilize more inclusive language in my nonprofit and have received some public pushback, specifically when we change the words women or moms. How is this best addressed? Samantha, I'd love to hear more about that. I'm wondering how the folks who are providing that pushback identify, and is that feedback in any way connected to this idea of kind of really limited understandings of like, well, who gets to call themselves a woman? You know, is it cis or trans folks? And who do we think of as people who are pregnant? I have more questions that come up as you pose that question, but it's something that very much came up in our September session as well. So would love to hear more context.
Samantha, I can go ahead and unmute you so that you can actually speak. And if you don't feel like typing out the context of the background behind your question, that might be a little bit easier. So I'm going to go ahead and, okay. So please unmute yourself and hopefully we'll be able to hear you.
Can you hear me?
Yes, great. Hi, Samantha.
Hello. Yeah, so it's mostly on like our social medias when we put out posts and we use, you know, inclusive, neutral language. It's definitely, you know, cisgendered women commenting, basically angry that we're stripping them of their identities in some way. And I think it's just they don't understand the concepts behind it, but it's also, are we going to spend every interaction trying to explain it to every person?
Right.
How this works.
Yeah, thanks for providing that, Samantha. I mean, that challenge, I think, has come up in so many different facets of my work. And I think that's why, you know, anytime I enter a project or I'm part of an organization, I think that deep relationship building has been really important to whoever we're serving, whoever our primary audience is to. And, you know, one of the things that I've really had to sit through and work out with folks is this idea of divorcing ourselves from our scarcity mindset, right? Of like, there are still specific issues and challenges that come with being a cis woman, who is pregnant. And we're not like this work and your organization and this movement isn't there to necessarily suddenly divest a bunch from that, but to make room for more folks who also need these services, who also need this work. And there's more than enough room and resources for everyone. And so having people kind of like, let's get down to the root here. Really, what is the fear, which I think you were already highlighting. And then what's the issue? The issue isn't necessarily that we're, pivoting attention away from cis women and their unique experiences to pregnancy or birth. But the issue is that we have such scarce resources overall in investing in, more inclusive practices when it comes to pregnancy and birth outcomes in care. And so always pulling people back up to like the systemic or structural issues rather than just like pitting certain identities or groups against each other. But I'm speaking about that from a perspective of like the community organizing work I do. I'd be really interested to talk to like someone who's really skilled in communications of like, well, how do you do that on social media? Because you don't have the same relationships there. And I'm interested, Samantha, like how has your organization responded so far? Or what has worked, if anything?
At this time, we pretty much just have said, well, we choose to use inclusive language and basically give a brief overview of everything you just said.
Yeah.
And it seems to make some people content and others not, but I don't think we'll ever be able to, change everyone's mind on social media. But I just didn't know if other people had these types of interactions.
Yeah, absolutely.
Thank you, Samantha. So Alyshia, we did receive some follow-up context around Elle's question earlier, and then there were some responses to that comment about neutralizing and being more inclusive. So I'm not sure which one you want to tackle first, but we did receive feedback on both points.
Cool. Yeah, well, let's go to, I think it was Elle's question was first.
Mm-hmm.
If you want to go to that follow-up.
Yep. Okay. So in her follow-up comments, it says, I am working with birthing people / babies / parents, and I always ask the person how they would like to be addressed. But I'm wondering, how can I deepen this knowledge and incorporate more inclusive titles in staff communications, presentations, research papers, etc. And so they're wondering if there are trusted sources to find this information.
Yeah, I'm wondering, when we say a more inclusive titles, are you referring to, like the formal titles of like Mr. or Mrs. or Miss? Or, yeah, I guess what I'm looking for is more of a definition around how you're using the word title. And Lynn, you're welcome to unmute Lynn too, if it's easier to have a conversation.
Yeah,
but also, you want to talk out loud, Lynn, or sorry.
It's okay, Elle, I gave you permission to unmute yourself, so you should be able to come and provide more context verbally, since it might be easier than typing it all in the chat.
Thank you. Yeah. So I serve as the Director of Maternal and Infant Health at March of Dimes right now. So titles is in, yes, like Mr. Mrs., but also just inclusive language overall in staff communications. And I'm just starting my position, and so I'm coming in and wanting to be as inclusive as possible. And so I'm wondering how I can further educate myself, because as a Black woman, I would hate to be asked like, hey, how can I not be racist? But
Right.
I wouldn't, I would hate to ask someone that question, because that's not their job. That's not their responsibility to educate me. So I'm just wondering, how can I find trusted sources to educate myself?
Yeah, that's a great point, Elle. And I definitely feel you on that, right? My experience with community members, and even my own experience as a queer person with a trans partner, has been that, making those simple asks, right, is actually incredibly important on like, and I always model it, right, of like, oh, my name's Alyshia and I'd like to be referred to by she, her, hers, how should I refer to you? How do you identify? Things like that. But your question on Mr., Mrs., and Miss really stumps me in terms of like titles, only because I'm just trying to think, like in my Pacific Islander organizing spaces, like that level of language and formality isn't necessarily how we interact with one another. So I'm interested to hear from other participants how that's come up for all of y'all, and how you've been addressing it. And maybe we can do some hive mind thinking with Elle here.
Thanks so much.
Yeah, absolutely. Thank you for posing that question. My partner, I see a question here. My partner is trans/non-binary and uses MX instead of Mr., Mrs., or Miss.
And I learned that that's pronounced like mix.
Mix, yeah. Yeah, that was my question too, right? Do we need to use these honorifics? Like in what situations, I guess, is that absolutely necessary? Because, you know, and I would love, maybe someone has a really cool like master's or PhD thesis on like the origins of these honorifics. Because, you know, for example, like in a lot of indigenous Pacific cultures, like we're not identifying ourselves through these honorifics. It's usually through like chiefly or village or like, you know, governance structures, but we're not using like Mr., Miss, or Mrs. Ooh, I see. My partner is a teacher and the school is heavy on honorifics, but that's a really awesome point. Yeah, thank you, Olivia, for posing that question. Okay, and there was another comment that we were supposed to revisit here, right, Lynn? Thanks for helping me keep track of all these. I'm excited to see how engaged folks are.
I know, me too. Okay, so it was going back to Madeline's comment about neutralizing or degendering language versus just being more inclusive. And scrolling in the chat, let's see. The first response I see along that thread is, it says, I typically feel like making language more inclusive should be the priority. When degendering or neutralizing language, we can actually erase or remove a part of someone's identity that makes them feel validated and important. Like as a person that uses she, her pronouns, feminine language feels true and special to me. Neutralizing does feel important when you don't know someone identifies as to not misgender them.
Sorry, I'm just trying to see where that, is that in the chat?
Yes, that one's in the chat and it came in at 37 after, if you're looking at timestamps.
Gotcha, I see, thank you.
Mm-hmm.
And neutralizing does feel important when you don't know how someone identifies as to not misgender them. Absolutely, right? And then starting with that question. And let's see, I'm just reading more of the comments here. Right, and I see Marisol just responded right after that, which was from personal experience within my family, asking the person how they identify and what pronouns they use. Introducing our own pronouns create a safe space to explore the person's identity.
Yeah, and similarly along those lines, the comment that came in before that also says just asking an individual how they would like to be addressed, asking open-ended questions to learn about preferences is also key to remaining inclusive. Some folks might take language that is neutralized or degendering as harmful or offensive.
Right. Yeah, I think the reflection piece that's coming up for me too is like, I think to Taylor's comment, right, around like validating someone's identity and the importance of that. I think that's always going to be important in this work, and figuring out like, how does that show up in our research questions is one thing. And then how does it show up in the care that we provide is another thing, and the engagement that we're doing with our communities. And the other layer of that is in trying to do research specifically on creating with more gender inclusive language, like how likely is that, like how will that body of research stand the test of time? because like these identities are always changing, always fluid, and always so contextual. Right? So like when I look at like old, like feminist theory from, 20 years ago, like there's like very different contexts and definitions in the way certain language and certain words are being used. And so a lot of time I spend some time like disentangling, like what are the higher level principles or lessons that I need to pull out of this piece, right? And it's not necessarily that woman is defined by X, Y, and Z, and that we should do everything that's opposite of expected of us. But what I'm pulling out is like, okay, well, there's a lot of different ways in which people can identify and define their womanhood, for example, and it can apply to both cis and trans women. And on top of that, the context and the definitions are always changing. And the principles that I get from it is, well, self-determination is really important, right? And the important teachings that I get from that research is about like choice, and people need to have choice in their lives. And so I do think, depending on the context, having gender inclusive language in the work that you're doing is really important. And then there's also like different phases at which we're talking about that work. Is it in engagement? Is it in providing care? Is it in research? And it's kind of negotiating, well, kind of what's the pros and cons and impacts, and like, how will this stand the test of time? And 10 years later, what's the possibility of someone misinterpreting this data or not making room for people to transform and even expand what they mean by things like womanhood or pregnancy or identifying with the pronouns she, her. So I have more questions than answers, Taylor, but as always,
So there is some feedback. So in follow-up to your comment about the context mattering and just being situational, there are a few comments in the chat that talk about, maybe if it's a big group, a broad conversation, then being neutral is more inclusive. But in smaller groups or in one-on-one situations, you can ask, since it is a smaller group, it's more feasible to ask people what they prefer, or just to be more intentional about like tailoring that inclusivity. And going back again to your point about context and how you're presenting, what you're presenting, and to whom.
Yeah, absolutely. Let's see, I'm looking at Laura Norton's comment too. Working in Portland, Oregon can be challenging for people of color clients when most providers are not people of color. Absolutely. And so we've tried to use more inclusive language and less bias. Something I have thought a lot about is using birth art in a way to encourage more of a spectrum of color and sexual preferences reflected in the room. We want all clients to feel comfortable and see themselves in pictures and paintings. Absolutely, right? Like, it's not just about the research, it's about the art, it's about the communications, it's about the providers, the researchers, and all of that being representative and reflective of the spectrum of people who are involved in pregnancy and birth. Let's see, I'm reading Kara's comment now. I think the challenge is that we are simultaneously educating and advocating while doing our work. Recently, I was on a great webinar that talked a lot about inclusive language and touched on the scarcity mindset as well, saying that we don't have to erase women or moms. Absolutely. We could simply add birthing people. When in doubt, more words equals more inclusive. I think you do a great job of this. I wasn't aware you'd gotten pushback, but also not surprised. And again, I go back to, I'm just a broken record at this point, the context and the positionality, right? Oftentimes having difficult conversations with cis white women in particular to say, right, and in broader US structures, right, there is a level of oppression that's experienced with being a cis woman, with being a person who is pregnant. And at the same time, I think it's also tied to this piece around scarcity mindset and white supremacy culture, right? And there's this tendency for, in white supremacy culture, for colonial norms around gender and gender roles and gender identities, like somehow they simply cannot exist without squashing other identities in its space, right? And I think the important part of like decolonial and indigenous values is this concept that I learned from Native women here, like Dr. Kelly Gonzalez and Jolene Joseph, who talk about indigenous self-actualization, right? And this idea that we can have power and affirmation in our identities without squashing on that of others. And so it's all tied to that scarcity mindset thing. But it's all, it's all about like your position in the world. In one space, you can be oppressed, and in one space, you can have an incredible amount of privilege. And in lots of scenarios, you can have a mix of both, depending on who else is in the room and in that space. But I say all of that to say, we still have to challenge this idea that only cis women get to be talked about or centered in birth outcomes. And again, who do we leave out when we center that? Ooh, I see Siobhan's question on, also, do you have any tips for degendering language in other than English, say Spanish? I do not. I don't work with Spanish speaking communities, but I encourage folks, again, this question came up in September as well. And I know Spanish is also can be a heavily gendered language at times. And that's really the extent that I know about the Spanish language in full transparency. So I definitely encourage any Spanish experts doing this work to chime in.
So I am not a Spanish expert, but in my exposure to different public health circles and to different like social justice circles, I have seen conversation about how terms like Latinx can be a moment of tension for people, just because like the addition of the X at the end is forcing like English-based grammar into Spanish. And so if you're speaking Spanish and then you have to say something like Latinx in the middle of your sentence, that can make it awkward for you, but it also just does not feel like speaking Spanish. And so I've seen people use the term Latine, so Latine, as opposed to Latinx, and that fits a little bit more seamlessly into Spanish grammar and just the way that Spanish is spoken. And that feels a little bit less like imposing Western or English grammar and ideals into Spanish. But also not an expert, that's just something I've seen. And I like that just because I know that, Latinx can feel kind of awkward when speaking. So just for whatever that is worth. And in the chat, actually, we see somebody has pronouns that are ella instead of ella or ello. Their pronouns are ella. Yes, see, and so thank you, Victoria, for also mentioning Latine. So it is out there, and there are people who are using it as well.
Yeah. And I want to go to Samantha's comment too of back to the English language as a colonial thought. I think it is key for entities to prioritize language interpretation and language translation throughout their programs and work. And I think that is such an important point that we don't get to talk about enough or even resource enough. So I am currently working with Oregon's Public Health Division, and we are trying to move away from using the BRFIS, the Behavioral Risk Factor Surveillance Survey, as kind of the primary data set that helps the state do their policies, programmings, investments, and go into something that is a community-based and community-created health assessment. And, for example, the Pacific Islands, right? We are talking about 3 major ethnographic regions: Polynesia, Melanesia, and Micronesia. And those 3 regions are home to over 20,000 islands, 30 nations, and a plethora of different ethnicities and languages. And one of the hard lessons that we continue to learn in culturally specific work is a direct translation from like an English assessment or questionnaire into whatever language you're focused on never works, and actually really skews with the integrity of the information and data that we're collecting. And I can't tell you in this last year alone how many times I've been a part of a project where, say, we're transforming language or guidance around COVID-19 it's written in English, and then we translate it into Chuukese or Marshallese or Chamorro. And the challenge there is, again, like gender, many other concepts around health, many other positions related to health and healthcare don't actually have direct translations or even terms in those specific languages. And so, I think my ability to do the work is very limited because I only speak one language, which is English. But we've been trying to transform systems to have them think about, well, what we need is like real language experts who are subject matter experts in this, in this area of work, like public health or health equity, who speak the language, who are also bicultural, right? Or heavily embedded in that culture. And so, because like, just think of the amount of iterations and revisions you go through when you're creating an intake form in English, right? Like, other languages that aren't English need that same amount of work. So I've been trying to move away from this practice of like, cool, we created the English form, let's go ahead and translate it into all of these other languages. We need to engage people from the beginning, right? Like, I want Tongan public health experts to be able to write a Tongan public health or community health assessment, and to be able to do that work, conduct that research, and analyze that data in Tongan. Because again, if we don't start to invest in those things, we're never going to hear those stories. Awesome. Thanks, Victoria, for sharing all your wisdom in the chat. And let's see, I'm looking at Elle's comment again of, I think what needs to change in shifting from a risk lens in research and moving towards what's positive and what's working in the community, in the population or community. This can help in creating more meaningful solutions. Absolutely. And I think the way that Dr. Duldalau and the work that I initially had done with her on reporting birth outcomes, right, is, do the 8% of COFA babies that aren't born at a healthy birth weight, do they matter in this work? Absolutely. But our idea here isn't to like solely look at them from the deficit space, right? Or solely look at that community from a deficit space. We're like, okay, well, let's think of like, for the 92%, what's going right for them? And I think Future Generations Collaborative, which focuses on fetal alcohol spectrum disorder and is led by our Native community here. They model that really greatly, where they say, we as Native people want to be here, but this is where we currently are on our birth outcomes. So how do we close that gap between what we determined as Native people as like our health metrics, or what health means to us? And again, I saw Dr. Duldalau do that in the birth outcomes work that I was doing with her. And so I think that's important, right? Like, what's the metric? Well, like, what are we having communities work towards? What are we having our institutions work towards? Is it pushing folks into some cultural assimilation, into healthcare practices that actually don't work for them or don't feel safe for them? Or can we push them towards meaningful solutions that they're invested in, feel relevant, is already happening?
So Alyshia, I think maybe we should switch to the Q&A box too.
Yeah, let's do that.
Yeah, and if you have more questions and comments and thoughts, please feel free to use either the Q&A or the chat. We're keeping up. I mean, it's a lot of really great engagement, and so we're just working through all the comments that come through. So please feel free to continue to use the chat while we go through the Q&A.
Awesome. Let's see. So for the first Q&A question is from Anushka here. It says, thank you so much for your presentation. I have a question about language. I've heard the phrase pregnant and parenting people as a way to get around words like mother or woman. However, I struggle with this phrase because parenting people to me also includes the people who are not pregnant. Do you recommend the term birther over pregnant and parenting people, or something else? So I would say it's about like getting really specific, right? Of like, and I, even in reflecting on my notes from the September session that I facilitated, right? Like, folks were also like, it's not just about birth, right? Some people who are pregnant lose their babies. So it's, getting to, I think, like, people who are pregnant, I think is the term that I've been using to be most inclusive when I'm interacting with folks, to recognize that, some folks lose their babies, some folks birth their babies. And let's see, there was also an additional follow-up of parenting people also includes parents who are not pregnant, but are still parenting. Absolutely. I want to see this other comment here, which is, you bring up a really important point. I think some of the things we need, oh, sorry, that shifted. You bring up a really important point. I think some of the things we need to do are change the fundamental definitions we use in parent and child health, such as maternal mortality, the death of women, to the death of a person. Absolutely. And here's another question. As a scientist organizer, ooh, I like that term, a scientist organizer. How do we create data collection systems that can nimbly respond to the constantly shifting and fluid nature of sexual orientation and gender identity? I'm going to throw this to the other scientist organizers who I know are in the chat. I would love to hear your thoughts or responses to that question. How do we create data collection systems that nimbly respond to the constantly shifting and fluid nature of sexual orientation and gender identity? You know, and honestly, that's something that I'm very much reflecting on right now, because at least for the community that I'm a part of, we're still at step one, right? Of like, how do we get them to even have more gender inclusive language or language and research and clinical intake forms that recognize that we exist as people and need access to this care or to this service? And I'll give folks a moment to respond if you have any ideas here. I'm going to drop that question in the chat as well. Oops, I just sent it to panelists. Let me do it to all attendees. I'm going to go to Susan's question while I wait for folks to chime in on what I put in the chat. But Susan says, my experience is that our dominant culture centers individual identity versus my culture, Chinese, where my identity lies with my family. How might we, address this in our healthcare system, respecting HIPAA laws and honoring identities that lie with family? I'm continuing to put those messages in the chat, because again, I think these are really specific contexts, and full transparency, I'm very much not a HIPAA law expert. I'm coming from a very grassroots organizing perspective, so I don't have to work in clinical systems or any sort of system that has I think really strict, compliance laws.
These are great questions though.
Absolutely.
Yeah, and they really demonstrate the need in all of our systems that we operate in for health.
Yes. And let's see, Victoria said, I think a divestment from check boxes towards visual representation of who we're serving would serve as a kind of tangible / practical way to see how client identities intersect. Like a Venn diagram. Ooh, there's another question here. Oh yeah, James. Data people hate this, but I'm a big fan of right inbox. Absolutely. And I will say in 2014, Oregon had passed legislation that required specific divisions within the health authority, with the Oregon Health Authority, to ask questions around race and ethnicity, for example, in 3 different ways, right? And again, I'm not necessarily an expert on this. I'm on the community engagement and community participation side of it all. But there, so we ask people to identify themselves in 3 different ways. There's one where it's just how do you identify? And then folks fill that in. And then there were about 35 plus racial and ethnic categories that were created in partnership with the community that broke things down, that disaggregated Asian from Pacific Islander, that, in the category under the Black community, there's Afro-Caribbean, Afro-Latinx, et cetera, et cetera. And then there was a third question that said, if you identify with, if you checked, more than one identity, do you have a primary racial or ethnic identity? Do you identify as biracial or multiracial? The challenges that we've learned, and I'm sure some of my colleagues who I know are on this call could talk about it in much greater detail than I could. One of the challenges is that even if we have really thoughtful collection forms, our data systems still don't match being able to, store and process that data, right? So everyone ends up, once it comes time for the technology to actually process that information that we collected, it all gets aggregated back up, or everything gets put into the other category. So there's all of these different systemic shifts that need to happen. And I'm seeing a few comments here, like ask them what they would like to be called. Sarah named that with HIPAA. I think an easy way to address that is asking during your first interaction with the patient who they would like their info to be shared with, so the ROIs can be completed up front, versus having it be an afterthought where a patient may need to come back to fill out paperwork or return forms later in order to share information. Thank you, Sarah, for providing that practical tip. Let's see, Whitney also says, we in WIC are moving forward with our discussions around inclusive language and struggling to come up with language with which we are comfortable, while also avoiding confusion around categorical eligibility because federal regulations currently prohibit trans women from participating in WIC. Yeah, Lynn, all we can do is give our head shakes in that situation. And I think it just goes back to the importance around policy shifts and systemic shifts and thinking about all the way in which, and I think there was a comment in the Q&A, right, where it's like, it seems like we were talking about trans exclusionary radical feminism, right? And absolutely. And just thinking about, when I think about cis women in particular who say, well, what about us in this field? And, why are we decentering, and this gender neutralizing language or this gender inclusive language really erases my identity? I think it's important for us to have a conversation about the amount of anti-trans legislation that is out there and how folks cannot access basic resources to feed themselves, to get housed, to have, safe and stable employment. Let's see, there's another question in the Q&A here that says, I'm curious if you know whether there are differences among Indigenous groups around the US and how their cultures have historically or currently treat or perceive non-binary and transgender people. So I can only speak to my experience of what it's been to be connected to my Native Hawaiian community. And again, the community that I'm organizing with here in Oregon. One of our challenges that's come up in the work that I'm doing with Pacific Islanders here is there is very much this entanglement between Western religion and cultural traditions of Pacific Islanders. And so we've had to have a lot of difficult conversations with our elders, particularly folks who are church leaders, around their ideas around sexual orientation and gender identity. But that's why it's so important to have people from community leading that work, right? Because, like, for example, we had in one of our community health assessments, we talked about community values. And in that definition of community values, we had respect for elders, which is a huge part of all Pacific Islander communities. And in our work with the queer and trans Pacific Islander organizations, we said, we're going to do something bold here. And in that definition of community values, we are going to put inclusion of LGBTQIA+ folks. And so in one of the data workshops that I led, one of the folks said, well, actually, it feels really inappropriate to me to have inclusion of LGBTQIA folks with respect for elders. Like, those two things are in direct tension with one another. Now, because of the amount of cultural humility and cultural competence that I think is being talked about in the field, I'm not sure if a white researcher or even a non-Pacific Islander researcher would be willing or ready to have that conversation with our Pacific Islander respondents. But that was something that I and the other researchers who were part of that project were very much ready to have. And the place that we landed on was that there's very much a conflation between Western religion and our community's ties to the churches, which is still really, really important, I have to emphasize, and I can talk about that more in a second. But the conflation of that with our traditional and indigenous practices. So there's like our indigenous practices, and that's one level, right? Thinking about pre-colonial history and our relationship to all these big concepts. There's like what our current cultural practices are, where it's typically a blend of pre-colonial and indigenous practices, and also the ways in which we've adapted to the Western world to survive, right? And then there's just like the straight up colonial practices. And nowadays everything kind of has its place, but we really have to disentangle the web of like, do we mean indigenous? Do we mean like contemporary culture? Do we mean just straight up colonial thought? But that's a conversation that we're always trying to have with our community. And sorry, I'm losing my thought because I'm just getting so much interaction here, which is exciting. It's a good thing. Let's see. Oh yes, Whitney, I see your comment. Absolutely, the biggest head shakes in the world. Gotcha. Oh, and I'm going back to that question that I had, right? Of like how cultures have historically or currently treat or perceive their non-binary transgender people. And I went on that rant about the research that I was doing with my community here, because it's a really difficult conversation for us to navigate through, because right now our community of Pacific Islanders do not feel and do not have a direct relationship with the state and different social service agencies. So most of the times when folks find things like food drives, when they find things like clothing drives, vital sources like affordable housing, or even temporary housing and shelter, all of that happens through our social structures. And right now that's the church. And right now the churches serve, and it can be Methodist, Mormon, Christian, Seventh-day Adventist, etc. But right now the church in the Pacific Northwest for Pacific Islanders really serves as the central hub for resources. And that can be a challenge, right? Especially for our queer and trans Pacific Islanders who very much need housing. But if you find housing, not through state services, but through your congregation, right? And at the same time, you're excluded from that space because there's a clash between like your indigenous cultural and gender identity and like the teachings of a church. That can be really, really difficult. So that's just, I could go on about it for like a whole nother 90 minutes, but that's just a window into, how queer and trans folks are experiencing, how queer and trans Pacific Islanders are experiencing life and community in the Pacific Northwest with other Pacific Islanders. Thank you for letting me go on that rant. Let's see, I'm moving through more questions here. In considering inclusive terminology, there seems to be multiple terms used for birthing persons, birthers, people capable of giving birth. Is there a specific term that is preferred, and any guidance or resources out there for public health workers working in this space, i.e. versus women of reproductive age, maternal health, etc.? I think that's a great question. And Marisol also wrote, there's a great resource in this area of interest. The World Professional Association for Transgender Health promotes evidence-based healthcare, education, research, public policy, and respect in transgender people's health. Awesome. And I can also share a few resources that folks actually shared. So I think it was one of our participants from the Colorado Department of Public Health and Environment had shared this resource on some research that was done around gender neutral language. And so I'm dropping that in the chat there.
I meant to copy the resource that Marisol put in the chat, but I'll just go ahead and type it again so that the audience can see it.
Ooh, let's get to this other meaty question here. So how do we decentralize whiteness when it has such a stronghold within hospitals and government? In my county, we are trying to reduce the infant mortality disparity in an equitable way. However, it is difficult to have a positive impact when the systems in place have deep roots. Absolutely. I.e., preconceived notions that Black people don't feel or are exaggerating pain compared to white folks. I'm interested to hear what folks think about that as well, and who has experience in transforming the cultures, the systems, and structures within hospitals or and government. I'll say that I purposely have decided not to work within government structures because I think a lot of the ways in which bureaucracy and systems are set up don't allow for meaningful racial equity and health equity work. But it's important to me to maintain relationships with folks in government who are doing that work, because if anything, if I've learned anything in my community and government partnerships, is that as a community member and a community advocate, I can often say things, be really forthcoming and upfront about what my feedback and issues are with the system or with a program or with an initiative or with a funding stream as a non-government employee. But that's why that partnership is really important, right? Of like, how do we build relationships with our folks in government or in hospitals who may not have necessarily the freedom or the power or influence to raise these issues in a particular way, but can give us information for like, I know, for example, like, they'll often say, I know getting meaningful translations and getting accurate translations is really important, but here's why we can't do that. The system will literally only allow us to contract with X kind of vendor, oftentimes because of some of the racial equity goals that we set out. But for some of our Pacific Islander languages that are, categorized as like hard to translate languages, those formal translation firms or agencies don't work for us, but that's the only thing that the county, for example, will contract with. And so, it's about working in partnership with those folks who understand, but don't necessarily have the power to change what we as community sometimes think is like a really simple act. It is a very simple act, but a lot of, I think, bureaucracy and government structures get in the way of us being able to do that.
There's another question in the Q&A that I think is a very natural segue based on your thoughts on the preceding question. It says, regarding the primacy of storytelling in health, thoughts on how we refocus funding for healthcare from white supremacist system requirements that focus on quantity of patients seen and risk-based metrics to hold space for people/families to share their stories, truths, and traditions.
Yeah. Siobhan's been posing lots of good questions and reflections in this session. So shout out to you, Siobhan. Thank you for asking that. Let's see, let me sit with that question for one more minute. Thoughts of how we refocus funding for healthcare from white supremacist system requirements that focus on the quantity of patients seen and risk-based metrics to hold space for people/families to share their stories, truths, and traditions. And I'm going to paste that again in the chat because I'm curious to see what folks who are working from this position of being a part of systems have done to really make that work happen. I'll say, I think the aha moment for the Oregon Public Health Division in the need to modernize the way they were doing data and to more deeply invest in community-led research was, so for the BRFIS, Oregon Public Health Division does, I believe it's like every 4 to 6 years, a racial and ethnic oversample. And so after 3 years of intentionally oversampling the Pacific Islander community, they only got 106 responses. Mind you, in the first 3 months that COVID-19 really hit Oregon, we had way more Pacific Islanders test positive for COVID-19. And so I think it was a moment, because of the amount of historical neglect and erasure and chronic disinvestment that we as Pacific Islanders experienced, on top of like the general modernization work that our public health systems were doing at the state, they were like, okay, we really don't know what we're doing here. We really need to like lend power over the way this research is conducted and even the budget to the Pacific Islander community. So I think that was a critical point of like, these methods that you're using don't even hold up. For Pacific Islander communities, yet only 106 responses after 3 years of intentionally oversampling folks. But again, I want to open up that question or those thoughts to additional folks who are participating, because I typically come into projects, I will say in full transparency, once systems have done some rectifying with and reflection on why they need to lend power or why they need to equitably distribute power over to the community. And I come in and work with institutions once they're ready for decolonized work. But for me personally, I'm not necessarily leading systems or governments or institutions through like, how do you get from this place of like centering white folks and white dominance over to centering like whatever specific community you're working on? One person said, make healthcare not for profit.
So I just put in the chat a link from an email that I got from the UCLA Center for Health Policy Research. And they're one office that I've seen do very intentional granular collection of information for the CHIS, the California Health Survey, I believe it stands for. And so if somebody's looking for examples of granular data and for data collection, that is one example, in addition to everything that Alyshia has talked about today. But just to backpack off of Alyshia's last comment there, the UCLA Center did a study and they found that like there is a desperate need for disaggregated information using cases and I think tests and registries and stuff that they gathered from the COVID pandemic. So in case you needed to reference a study that somebody else did in order to make that case for your own jurisdiction as well for disaggregated data.
Thanks, Lynn. Thanks for sharing that. And I realized again, I went off on a tangent and a whole separate string of thoughts, and I didn't come back to one of the central points made in that question around, decentralizing whiteness when it has such a stronghold within hospitals and government, right? And that example of preconceived notions that Black people don't feel or are exaggerating pain compared to white folks. I think we have the difficult task ahead of us of like, how do we actually understand one, the pervasive nature of anti-Blackness, even within communities of color, because it very much exists. I think this is pointing to a really specific issue here. And the other piece too is how do we start to frame racial equity or continue to frame racial equity, because plenty of folks have been doing this work for a long time, not just as like feel good work, right? I mean, that's an important part of it, right? Like relationship and love and care and healing for the communities that we serve. But the other layer of that is how do we have people understand that if you want to be a medical practitioner, especially a medical practitioner serving the most vulnerable communities, then racial equity is a required skill set. And you can't say you are doing your job if you don't understand the pervasive nature of anti-Blackness in the medical field, right? Like the example that I give, and this isn't related to healthcare, but my sister works on the East Coast. She is a labor attorney. So she works with a bunch of different unions. And the whole goal of the organization that she works with is to serve the most disenfranchised and marginalized workers in the union. And yet at the same time, 70% of the union workers that they end up reaching or serving are white folks. And when we investigate systems of racism and of anti-Blackness and of white supremacy, start to question that, like, well, can you really say you're serving folks or doing your job if you're not reaching like whole key areas of your population? And sorry, I'm seeing more things come up here in the chat. So Ashley shared, also create space for people to be at the table, allow families to contribute their experience and community knowledge to contribute to projects. Sorry, another comment cut that off. Further projects, further equity and inclusion, i.e. Caregiver Alliance. I specifically work in community benefit for a not-for-profit hospital. And then Dr. Doldalau says, I think part of the refocus is building relationships with people in government, as Alyshia said. The public health modernization work that I'm currently leading with Oregon Health Authority is the direct result of years of relationship building, calling people in, and basically talking about decolonizing and anti-racism in public health all the time. For the most part, people in public health want to do the right thing, but sometimes they don't know what that right thing truly is. Absolutely. Thank you, Dr. Doldalau. And then let's see. This last comment here says, much of the reporting and service requirements come directly from the federal government and legislature. We need leaders at high levels who are aware of these issues to help move the services and indicators so that they are more culturally respectful and appreciative. Absolutely. Some things, especially in regard to data collection and measures reporting, are dictated in the funding grants. Absolutely. And I think I've seen that more than ever with COVID-19 and the need for all of levels of government to collaborate with one another and to really, like Dr. Doldalau was saying, be in consistent relationship with the community to learn what's going wrong, what do we need to do better, and what does that actually look like to transform our systems.
So Alyshia, we are at 29 past the hour, and I'm not sure if you want to take in one more question or comment from the audience, or if you have any closing thoughts, but I want to be respectful of your time. So, I'll leave that up to you.
Yeah, thanks, Lynn. I just want to give a big thank you to everyone. I know my presentation was really brief, and that's on purpose. I just wanted to start this thoughtful conversation. I personally don't like listening to people speak for 90 minutes at me. So I love more of this conversational aspect. So I just really appreciate all of the different questions and scenarios that people posed, some of which I have experience in and a lot of which I'm still learning about. And so I'm just appreciative to everyone who's invested in this work, who showed up to today's conversation, who contributed their ideas, their challenges, their learnings, and the things that they're committed to. And as always, thank you to CityMatCH for giving me the space to share some of my own lessons and ideas and opinions. And I will say, I'm going to add in one last resource. Now, this is very much specific to the Native Hawaiian community and very much specific to this idea, the concepts that I pulled from around gender, familial structures, and language. But I very much encourage all of you to read Remembering Our Intimacies. It is the PhD dissertation of Dr. Jamaica Osorio in the University of Hawaii. And I think it pulls all of these concepts that I talked about in terms of decolonizing our frameworks so beautifully, and why having an expanded understanding of gender and sexuality is critical to decolonization work. So I offer you that as my kind of last resource and offering to close out today's conversation. But thanks again, everyone, for your time.
Thank you so much, Alyshia, for your presentation and for how much time and care and thoughtfulness you put into responding to questions and comments and really being open to having a discussion with our attendees. I know that every time I talk to you, I learn something new, and I'm just so impressed by everything that you're doing for your community in Portland and in Oregon as a state. So thank you again. I appreciate you. We appreciate you. And for everyone in the audience still, this session was being recorded and we will make it available to you. We upload these webinars onto YouTube, and then I'll send it out to the registration list, and then we'll host it somewhere publicly as well, so that you can continue to revisit this conversation and share it with your colleagues, and hopefully continue this conversation locally about inclusivity and decolonizing parent and gender health. So thank you again, Alyshia, and thank you everyone for joining us. I hope you all have a wonderful afternoon. And stay safe out there.
Awesome. Thanks, Lynn. Thanks, everyone. Take care.